spongy tissue and it is slightly firm enough. So it doesn't, because of the spongy character of the Teflon, it does not permit any mechanical pulsation to get transmitted. It acts like a shock absorber. But it is firm enough at the same stage, so it does not allow it to be transmitted across. So once you put the Teflon in between the loop and the nerve doesn't get stimulated anymore and they almost have instantaneous pain relief. The biggest advantage is when they wake up from anesthesia, their pain is gone. The next day they don't have to take amlodipine or pregabalin again, and they can eat their breakfast the next day morning. They are very thrilled about it. So what do? We do a retronaspect craniectomy. I'm sorry, in the video I have not been able to transfer because I wanted to show you the video specifically for this. But what I can tell you is in this position, I'll just give you an idea so that if anybody needs counseling, you can counsel a patient. The incision is done behind the temporal bone because that is the area where we can go and approach the system. We can go back to this. So you can see that this is the temporal bone and the external auditory meatus is somewhere here. So we take an incision laterally here so that we get this corridor between the cerebellum and the vitreous bone. So for that we make an incision behind the ear. So you can see the pinna out here. So just on the mastoid bone, we make an incision, drill the posterior aspect of the mastoid bone so you make more space, retract the cerebellum very less, and once you open the arachnoid there, you can see the nerve crossing over from the brainstem into the Meckel's cave. And exactly at that location, we can see the nerve and the artery crossing each other. And all you need to do is separate them with the dissector and position the Teflon in between. So I'm just going to show you this long term. This is one of the largest series that has been published in literature by Janata. Janata is the guy, a British neurosurgeon, who propounded this theory and started doing this procedure confidentially. And following him now, it's a worldwide accepted procedure for being done for trigeminal neuralgia. So he has done more than 1,000 cases over 20 years. And in his hands, the recurrence-free, pain-free rate, even at 10 years, is more than 70%. And even in that, about 11% of recurrences underwent surgery again. And they are pain-free. So adding on, you can say it's about 80%.
We didn't know what the treatment was given through surgery. They
for
were
over a
just
period of
saying
even 20 years,
return of the
further
nerve
paper
giving
of
anesthesia.
20 years follow-up,
But what
it
he
says
said
that
was
almost 80%
excellent. I
brain
mean,
injury.
that is the reason for
That is very
that time we didn't know
crucial
what's
because
the
the
reason
other
for that.
procedures
Now
what
we
I
know the
discussed
reason. Could be
are
a tumor or
we
it
talk in
could be
terms of
just
5 years,
vascular loop touching the
talk
nerve.
20 years.
That time it was total mystery.
And as you can see here, the death rate, mortality is 0.2%, very less, and there have been no significant morbidity. Hearing loss is about 2%, CSF is 1%, and cerebellar hematoma has been 0.2%. And now, this is for RF lesion. Suppose the patient cannot undergo microvascular decompression because I'm putting in the reverse way instead of starting with RF lesion because if a patient is fit, young enough, and there is no anesthetic risk, we should counsel them to go for the surgery because it's long lasting, it's very low morbidity, and they did not have recurrence for a long period of time. But if for some reason surgery is not possible, patient is afraid or patient is not fit for anesthesia, then we go for percutaneous procedures. So what are these percutaneous procedures? The commonest being done nowadays is RF lesion. It's a radio frequency lesion. What is done is a metal needle is passed through the face directly up to the foramen ovale under C-arm guidance or under CT navigation guidance. And the needle tip is insulated up to the tip. So only the tip of the needle can conduct the RF energy. So it can be heated up to a temperature of about 60 degrees. And the principle goes like this: if you give the RF, there is a RF lesion generator machine which is connected to the needle. So we do it typically under a short propofol anesthesia. So patient is not intubated; he is lying down comfortably. The anesthetist gives a shot of propofol so he doesn't have the pain of the needle puncturing up to the foramen ovale. Once we think we are in the right place, we stop the propofol. Patient wakes up, and he can tell you. We can give stimulation through the needle and find out which area of the ganglion we are. Are we V1, V2, or V3? So when we give the current, and if he says I'm getting tingling on my forehead, that means you are in V1. You should not burn those fibers. If you burn those fibers, he have hyposthesia, including the corneal region. So then you withdraw the needle a little more, again give the current, you get you get paresthesia on the cheek. So you touch there and ask him, do you have any tingling sensation here? He says yes. Then you check in the bangle. So if he normally has V2, V3 problem, which is normally 80% of the people have V2, V3 problem, and he confirmed that the needle still is in V2, V3 by giving the current, all we need to do is send the RF energy for 1 minute. So we set it for 1 minute at about 45 degrees centigrade. So if the temperature on the tip rises to 45 degrees centigrade, then the timer starts counting down for a minute, and then it shuts off the RF energy. So what it produces is a very small lesion within the ganglion at the particular nerve fibers. So that produces a mild hyposthesia in the patient, about 10-15% hyposthesia, and it takes away magically the pain. So here also the pain is instantaneous relief. Patient will wake up and will go home without any pain. The only problem is the hyposthesia can be quite significant for some patients and troublesome. The other problem is recurrent. This is short-lived. It can get recurrent in 6 months, 2 years. If it is done well, it may last up to 5 years. But most people do get recurrence beyond 5 years. So if you are having an X-ray and somebody in their 40s, you don't want them to keep undergoing RF again and again and again. So it's best to tell them, go for a microvascular decompression. Till 60 probably you will not have a recurrence at all. But if a patient comes at 60 or 70 and has the same problem, and if he has other comorbidities, then you can think and say, look, you have both options. You are willing for surgery, go for surgery. Otherwise, RF may be a good option. So that's how RF helps. So summarizing RF, what all it does, it's definitely a minimal invasive procedure. It's just percutaneous. And you have to check that the division is not involving V1 division, so that it should be sparing. So if somebody comes with a predominant V1 involvement, trigeminal neuralgia, straight away is not a candidate for RF, whatever his medical condition is going to be, because it produces hyposthesia. You should be wary that BP can shoot up during the procedure. So because you are stimulating the trigeminal ganglion and there is a reflex sympathetic phenomenon that can get activated because the sympathetics run close by and they can get high blood pressure, and subarachnoid hemorrhage and hypertensive hemorrhages have been reported with RF lesion, though it is very, very less than 1% chance. So if a patient is hypertensive, most of these people elderly are usually are. So you have to make sure that they are not unnecessarily not controlled with hypertension. First, get the hypertension controlled before they go for RF. It gets good immediate relief, but the benefit may be short lasting and the recurrent rates may be high. And it's very suitable for patients who are elderly and who are at high risk for surgery, especially in the V2, V3 division. Now I'm going to quickly tell you about radiosurgery. This may be totally alien topic to you, but I just need to make you understand what this procedure is, because this is coming up again in a big way where neurosurgeons and radiation oncologists together help treat these kind of patients without doing a surgery. So radiosurgery is actually a misnomer. What it actually does is, it's nothing but radiotherapy. But it's a very focused radiation. The entire beam is not radiated for a full field, but it's radiated in such a way that all the beams are radially focused on to the nerve. We use it in acoustic tumors, we use it in AVM, we use it in benign conditions. So in a three-dimensional volume, stereotactically, accurately, we can outline the tumor or outline the nerve and make the beams fall only on the volume that we want, so that there are no radiation in the surrounding areas. So all the beams will focus on to that one point only. So what happens is that produces a damage of the tissue in that region. But this radiation, what we use in trigeminal neuralgia, is very, very high. So suppose this is the nerve, this black line is the nerve. You can see this red markings around here. So that is the area the beam is being focused. So once we do the planning, the computerized system of stereotactic radiosurgery takes over. It matches the images. We can do online imaging while we are shooting the beams and make sure that the beam is being shot in the right place. That's why it's called stereotactic radiosurgery. So once you do the dose planning, this dose that we give for trigeminal neuralgia is much higher than what we give for tumors like acoustic or meningiomas or AVM. For example, to give you, we give about 15 gray dose. Normal malignancy is an extended field radiation. You give for the whole area field, and it's given about 50 gray over 30 days. But for radiosurgery, we deliver about, if you deliver it in one shot, the equivalent of 55 gray or 60 gray, we can give in just 10 or 12 gray in one day, in one shot. But to do that for trigeminal nerve not to conduct properly, we have to give about 80 to 90 gray. That is very high dose given in one shot. Imagine the extent of radiation. It is called a necrotizing dose. If you do MRI of this nerve, after a period of time, you will see that the nerve is dying and it is also undergoing necrosis. But this is only the sensory component. The motor is very resistant. Nothing happens to the motor area. It is somehow radio resistant. Just the sensory part gets damaged, and the sensory part also does not become hypoaesthetic. They just have relief of pain. But you are giving such a high radiation, so even though it is focused, the surrounding tissue will definitely receive some radiation. So the longer the patient lives beyond the radiation, you will see the side effects of radiation much later. And we don't know what that is going to be. You can have a second tumor, you can have a malignancy or something, which is always associated with radiation. So we cannot take radiation actually as a non-invasive procedure. Though we don't put an incision and we say it's minimal invasive or it is not a surgery, it is accurate like a surgery. That's why they have labeled it as radiosurgery. It is actually, it could be invasive. So the problem, induced side effects may occur much later. But the incidence given is less than 4 in 1,000. So you don't have to really worry too much about it, especially if you are using it in patients who are elderly and who cannot be offered any kind of treatment which are involving putting a needle in. Suppose uncontrolled hypertensive, somebody who has undergone cardiac valve replacement, you cannot stop his anticoagulation. So you can't even stick a needle. And his hypertension is high, if he bleeds, he will have a massive intracranial hemorrhage. So how do you treat this patient? Radiosurgery is a good option. But not for a patient who is 40 years old who is coming and saying, I don't want surgery, I don't want a needle sticking, give me radiation. No. We should say, absolutely discourage them from undergoing radiation. And what is this type of radiation? The machine that is used goes by various names depending on the source of energy used and by the company that manufactures it. So there are companies which manufacture gamma knife because they use gamma rays, companies which manufacture X knife which use X-rays, or cyber knife which uses a robotic arm to be more accurate. So all of them do the same thing. We also do radiosurgery using an X knife machine called Novalis TX. So it's only the company that is different, but the technology is absolutely the same. So we can perform RF listening, we can do radiation, and we can do microvascular decompression. So how do we choose the patient? I have shortly given you already what all that you can do. So I'm going to conclude giving you a quick recap of what we have seen. So it is a pure clinical syndrome which can be diagnosed when the patient comes to your OPD and describes the symptoms. And usually it is good to search for a cause, because if it is treatable, then medical management will not have to unnecessarily keep doing. So if you find a patient of trigeminal neuralgia, ask for an MRI, at least to rule out tumors, even though it is seen only in say 5% or 10% of patients. If there is no epidermoid, no schwannoma, this patient can be treated only medically. The medical line of management is the first line of management if there are no mass lesion diagnosed on an MRI. And medical management, good medical management can be with pregabalin, low-dose carbamazepine, with or without amitriptyline. If it is refractory to medical management, then we think of intervention. And what will be the intervention of choice? Young, medically fit, old but medically fit patient to surgery with microvascular decompression would be the treatment of choice, because morbidity is negligible, good long-term outcomes. But if it is elderly patient, lot of comorbidities, then RF ablation may be a good choice, or stereotactic radiosurgery in a patient who cannot be undergoing any intervention at all. With this, I will conclude and thank you so much for your attention. Happy to take any questions.